I think we are making a tremendous progress in terms of molecular testing and what we can know and what we can learn with these patients. We really, I think, is a general consensus now that it's not just the histology that determine the biology or natural history of these patients. It's a different mutations, either mutations in oncogenes or loss of the tumor suppressor gene that define the biology of this disease. I mean, one thing I think what we'll be really struggling over the next several years is, how many more of these molecular testing that we can actually order and test, because you're talking about some of the molecular changes that happen in about 1 to 2% of the patients. While as a clinician we are wondering if the technology is moving really fast, that there are different platforms now that you can test for a large number of these mutations in one setting. And I think these are still a bit costly to get in a routine clinical practice, but as the price come down, I think that's where I see the field of lung cancer going, is I think we'll really be tailoring our treatment for a lot of these patients based on different molecular markers. Now we all now talk about some of these known mutations, EGFR, KRAS, and EML-ALK, and that's really only the tip of the iceberg. And I think we know that not even the same KRAS mutated patients, two patients with the same KRAS mutation could have a completely different natural history and biology of the disease. So that could potentially be there are other driver mutations beyond these things. And I think what will be the challenge for a lot of clinicians and all of us to see how these different mutations interact and how these things plays in terms of what are the better target that we can use to treat some of these cancers.